Maybe we should get started. Uh, Good afternoon. My name's Sandy Auerbach. I'm from the Sleep Disorder Center at Boston Medical Center and Boston University School of Medicine. Uh, Today's speaker is Goli Parsi, who's from the School of Dental Medicine at Boston University. Goli's boarded in orthodontics and in uh, dental sleep medicine. She did her training initially. She got her doctorate of dental sciences at the University Pacific School of Dentistry, and then had come to Boston University, where she did a residency in orthodontics and in um, dental facial orthopedics. Uh, she's now associate professor at the School of Dentistry and supervises the residency program there in the clinic as well. Uh, she's going to talk today about microbiome relationship to obstructive sleep apnea, something that's, at least for me, was a little different when I first started to work with her on this. So, uh, with all that, Goli.
Thank you so much, Dr. Orbach. Hi, everyone. As Dr. Orbach just explained, I'm not a physician, but a dentist, orthodontist. I'm sure a lot of things that I'm going to go over is going to be pretty matter of fact to you all. So I'm going to start out with, obviously I don't have any, what is this one? Conflicts to report. This is our department of orthodontics at Boston University, across the street from the Boston Medical Center, and this is our team. The front row is the full-time faculty, and then we have a 24 residents, 8 each year. So we have a 3-year program for our residency, and we work together clinics and then in research. You might think that why orthodontists who generally would be sort of treating these sort of discrepancies within the teeth to something that would look like this, or something like a bite problem where we have these like huge overbites into more aligned alignment and that. And then if we have a significant discrepancies between the jaws, then we would do, in conjunction with orthognathic surgery and braces, sort of rehabilitate that. How do we come into play with airway in general? What we started doing a few years ago was to incorporate a lot of screening questionnaires, especially for our pediatric population, as we were seeing a lot of snoring, congestions, and breathing problems, and behavioral problems too. So we started out with the Bears questionnaire. That was a very quick way to check some bedtime problems, any daytime sleepiness, and awakenings during the night, and any irregularity of the sleep, and ultimately snoring and their airways. And if there were any issues on any of those questions, then we would delve deeper with a pediatric sleep questionnaire with the domains of the nighttime and sleep behavior versus the daytime, and sort of maybe hyperactivity and focus issues, more so than other things. And sort of, if any of you are familiar with this, this has good validity, specificity, and sensitivity questionnaire. And if we see about 8 questions that are answered yes or applied, then that puts these patient of ours into a higher risk for sleep disordered breathing out of the 22 questions that there is. So then we go in and we started doing our clinical examination with a little bit of, focus to more than just the teeth. And we started looking at the tonsils for these kids. And then if we had the Brodsky score of 3 and 4, we would be more amenable to make referrals. The Mallampatties of 3 and 4, again, we started paying attention to. And then if we had these scallopings around the tongue, if we had the tongues that had these almost like tongue ties, or these sort of the white coating of the papilla, especially with the mouth breather children, we started to have them, sort of again be referred. And then when we had the arches that were narrower here with, and then with not having enough space, then we started making referrals then too. And what we do have access to is three-dimensional imaging that helps us look at the volume of the airways, as you can see in both the sagittal and axial views. So again, we have a lot of sort of resources that we use for routine tooth movement in general, but we get a lot of information about their airway also. And that's where it all started for us to look at, to be part of the team that looks at maybe adenotonsillectomy as the first route, the CPAP, nasal corticosteroids, but then also too, if there is any need for rapid maxillary expansion or any advancement appliances, if there is anatomical problems, for us to be able to play a role and also to help with the orthognathic surgeons. We worked with one of the former faculty at BMC, Dr. Rana, to come up with this review to how to help within the whole flow chart of these patients with sleep, with airway problems, and then where there was within this flow chart, if there is obviously allergic rhinitis present, we're talking obviously a different path. But then when there was some malocclusion and dental abnormalities in the whole picture, then maybe we could come into play with our rapid maxillary expansion and mandibular appliances. And many craniofacial abnormalities, maybe we can be of help with mandibular and maxillomandibular advancement and specialized surgical procedures. So with that in mind, we started doing these appliances that we could see that affects the airway as the bones are pulled apart from each other, and how that will help increase the airway volume as the before and after shows here how the jaws are widened. I'm just sort of brushing over these to give you an overview of, how we got to where we got with, again, our imaging showing us that as we're trying to widen the skeletal here, we do see how the sinuses are enlarging, that the nasal volume is enlarging, and all of these areas are showing increase in airway. And for instance, this would be a case where we had the tongue tie, we had really narrow arches, and we did the palate expansion and widened both jaws, and this was sort of middle of treatment. And he was falling asleep in the chair when we started. And by the time a year later, when we got here, his AHI had significantly dropped and was under 5 finally. And then we started doing some research on looking at the effect of rapid maxillary expansion on the airway of the right and left side of the nose. And we saw that by doing that, we were able to sort of normalize the discrepancy between the two sides. And we showed a significant increase. We started using double jaw advancement for severe OSA cases where both jaws were then advanced. We had braces on and jaw surgery, and as you can see, both jaws are brought forward, and significant increase in the volume and significant decrease in AHI and quality of life changes. Again, that is quantifiable with our routine sort of radiographs that we take for our pre and post-op. And again, this is another project we had on the effect of surgery, where we saw if the maxilla was advanced alone, how it significantly increased the oropharyngeal cavity. If the mandible was advanced, again, significantly oropharyngeal cavity was increased. And if there was biomaxillary advancement, we had on several levels of nasopharyngeal, oropharyngeal, and hypopharyngeal levels. And the minimal cross-section was also too increased. Then last year, we actually started looking into the epidemiology of the ethnicity and the sort of skeletal discrepancies in a multi-center study across several countries. We had collaborators in Japan, South Korea, Saudi Arabia, and South Africa, and our general orthodontic population here at BU. And what interestingly we found was previously the Middle Eastern ethnicity that wasn't really looked into separately as the white Caucasian was generally looked into, that actually showed a higher incidence of sleep-related breathing disorders. And the male gender as expected, higher BMI. And then there were several findings within their lateral cephalometric, sort of their pattern of the skeleton, the gonial angle of their mandibles that showed a predictive value, as well as the hyoid bone relative to the mandibular plane. So that sort of got us interested in, getting into this pediatric OSA, and how we started noticing that these mouth breathers would show different rates of cavities and gum problems, periodontal problems. And when we started looking into more of what was out there, we saw that as far as the microbiome, the GI microbiome had been studied the most. And it's dysbiosis too, that had been linked to obesity and cardiovascular problems and depression. While we thought, well, we're in the mouth region, and as they're connected, there may be something there. So why don't we look into that? And actually, we first started thinking about this around COVID time, and we wanted to collaborate with Boston Children, Boston Children's Hospital. We had the IRB approved and everything to get started, and then the lockdown happened, and there was a lot of limitations to how many sort of staff we could have rotate there. And then once things got back to normal, we never picked it up, and ultimately until now that we're getting back on it. So Dr. Orbach wanted me to give you all a little rundown of what we've learned in the process of as we got interested in the topic. And like I said, I'm sure that most of you knows more about this than I would. But again, just an overview and how we got to where we got, and what we have planned moving forward. So as far as the microbiota that we're going to be looking at, it's a complicated, diverse, and abundant community of bacteria, viruses, and fungi. And these cover every surface of our body, obviously, that's exposed to the environment. And they outnumber our human cells by maybe in the realm of like 10 to 1. And during development, then they colonize specific parts of the body according to their biogeography. So they show diversity between different people and different locations within our body. So the ones in the GI tract versus the urogenital or skin or lungs or subsides of the airway would obviously, as expected, be different. And majority of them, around 70%, as we know, are in the GI tract, and that is the most studied. And their ecosystem is quite diverse, and it's affected by our diet, our lifestyle, environment, and microbial competition, and even circadian rhythm. There are generally two types of microbiota. It's the core microbiota and the secondary ones. The core microbiota is basically that group of microorganisms that are common in 95% of us. And they sort of run the metabolic and immunological functions in the areas that they colonize, or that symbiosis. And when the health status varies, or that dysbiosis occurs, then the proportion of this bacteria is what changes. While the secondary microbiota is basically the remaining ones that are not shared amongst different individuals. So be it the most studied microbiota in the gastrointestinal one, there's, under normal conditions, there's mutualistic relationship between the host and the gut microbiota, meaning the host, our body, provides nutrition and a suitable living environment for the bacteria. And the microbiota then in turn helps maintain the immune response. It acts as a barrier from the invasive pathogens, and also to contributes nutrients to the host. But this mutualistic relationship could be compromised when there is a dysbiosis, meaning that shift in the composition of the microbiome, right? So It's widely accepted that the gut microbiome plays a crucial role in biologic processes like metabolism, like immune regulation, some pro-inflammatory and some of them anti-inflammatory, and circadian rhythm variation. For years, though, the human gut microbiome has become known to be a therapeutic target too for preventing and or treating chronic disorders. And also too for extending human longevity and healthy lifespan, as you all hear a lot about probiotics role and such. What is dysbiosis? That is the imbalance within the microbiota structure or the functional community that's associated with medical comorbidities that could be, for instance, it could be that we know that microbiota dysbiosis was suggested to be involved in OSA, and that's what we're going to be focusing on today. Where there is a shift in the composition of the microbiota, it can compromise that mutualistic relationship I was just talking about between the host and the microbiome. And some triggers for this could be overuse of some antibiotics, infectious agents, and even our diet, which again, I'm going to go over in a little bit. Changes to the gut microbiome has been linked to several comorbidities, and these are typically different for different ecological landscapes. For instance, like within the skin, it could be related to psoriasis. For the oral dysbiosis could be like lichen planus, periodontitis. For the lung, it could be pneumonia, for instance, or the GI would be colorectal cancer, liver disease. And as you can see here, a few I just put down on this slide with inflammatory bowel disease and obesity and diabetes and autism and all that. That has been some records of it in the literature. And heart disease, especially with hypertension that we see in OSA. Now, talking about OSA and looking at OSA with this gut microbiome, let's sort of break it down and see how the progression of the events are. Where we have this obstructive sleep apnea, and there's this repetitive pharyngeal collapse during sleep, then these apneic events result in intermittent hypoxia, as you all know, and hypercapnia. And there's also to increase sympathetic activity. Now, this sort of puts the body into the systemic inflammation state, and there's these free radical production that happens. And this finally triggers the inflammation, sort of triggers the change in microbiota, and ultimately the organ damage, a sort of a oxidative stress cascade that can lead to all of this. And OSA now, as it sort of as a hallmark of it being the intermittent hypoxia and sleep fragmentation, now contributes to this intestinal dysbiosis, causing the systemic low-grade chronic inflammatory changes. And I think there is just enough robust evidence in the literature sort of connecting the inflammatory changes with sleep disorders in general and obstructive sleep apnea that I think I'm not sure if there is much debate on that. I think that's pretty accepted. So therefore, ultimately, this intestinal dysregulation may trigger or exacerbate any organ damage in susceptible patients, for instance. And patients who have OSA do show significant imbalance in their intestinal microorganisms. So we have Clostridium that has been shown to, there's imbalance with like the different strains that we look at, and ruminococcus and the bacteria, especially bacteria that produce short chain fatty acids. Those are the most affected that we notice. And in general, there's a decrease in specific diversity of the microbiota and the way that they're distributed and their metabolites that then promote the development of complications. Any modulation of this microbiota with adjunctive prebiotics or probiotics if we use it as targeted therapeutic interventions, then this can play an important role in alleviating or even maybe preventing these adverse outcomes associated with OSA in children. So, but again, trying to figure out specifically what strains we're looking at, where the imbalance occurs, which ones are going to be affected, and then how to target the treatment. I think that's the big question. Another point would be to look at it the other way around, meaning the gut microbiome, how that will play a role in development and progression of obstructive sleep apnea. So let's look at it again, where OSA would be causing that intermittent hypoxia. There's periodic decrease in oxygen levels in the blood, and the GI system. Now there's favorable condition for bacteria that thrive in these low oxygen environment, right? So the studies have shown that any changes in the composition of the gut microbiome, like this decrease in the good bacteria and an increase in the bad bacteria, can lead to inflammation and metabolic dysfunction. And then there's several studies that show that patients with OSA have a different composition of gut microbiome compared to controls without OSA. So there was a study that induced intermittent hypoxia in mice for 6 weeks, and they found a significant impact on the overall microbial community, where the Firmicutes were increased and the Bacteroidetes were decreased, and the proteobacteria also too decreased compared to the control mice. So I guess the big question here again is that, can we devise a microbiome-based therapy? Could it be as an adjuvant to the treatment and limiting the comorbid consequences? So many dietary components we know that can affect OSA by targeting the gut microbiota, or we hope. And then studies have found that lower bacterial diversity was shown in people on high-fat diets, the same way that lower bacterial diversity was also shown in patients with OSA. But on the same token, I guess on the opposite side of the spectrum, we also see that where there is microbial fermentation of the dietary fiber produces these short-chain fatty acids, which again, those are the good bacteria that make these, and these reduces the bacterial translocation, maintains the intestinal integrity, and reduces the inflammation. So again, things to think about for the therapy aspect of things. The few articles recently published, the feces of OSA patients show significant reduction in lactic acid, or those short-chain fatty acid producing bacteria. That was done by Ko et al. Another group, Wang et al. In 2022, showed that thick-walled phyla numbers were increased and the bacteriophage numbers were reduced in the gut microbiota of the OSA patients. And Collado et al. Showed that there was a higher abundance of the proteobacteria and the Enterobacteriaceae family in the gut microbiota of the snoring children, and significantly lower microbial diversity. So all of these are talking about lower diversity, which is not good, and how we're losing that richness that the normal population leads to that inflammation sort of status for these children or OSA patients. And another one, a reduced number of microbial species, also to in children with OSA. This article was just published last month. It looked into the gut microbiome in patients with different OSA severity. And they looked at 45 OSA patients, 19 healthy controls, and they sort of separated them based off of their polysomnography findings for the severity. What they found was that there was alterations in the composition of the microbiota in the gut in patients with different severity levels of OSA. And in severe OSA patients, they saw a reduction in the relative abundance of these short-chain fatty acid producing bacteria, the Bacteroidetes, the Ruminococci, and those were significantly decreased. And there was a significant increase in harmful bacteria also too. So in summary, in a way, the results showed that there was this difference in composition of the microbiota, which is mainly related to these short-chain fatty acid bacteria. And these may play a role in the have a pathological role in the metabolic comorbidities that are associated with OSA. So that's one. Here's another study that looked at the intermittent hypoxia and hypercapnia that were exposed. This was a animal study that they ultimately found that these mice were exposed to intermittent hypoxia, and they saw perturbation in their gut microbial population. And then there was the findings were that there was significant alteration in their bile acids between the experimental and the control groups, and elevation in the phytoestrogens and alterations in their fatty acids. So again, we're still talking about the gut microbiome while we're working in the mouth. So we thought about this, that, okay, so we know all this information about the gut microbiome, but the oral cavity and the intestine share the same digestive tract. And we know that OSA could markedly alter the gut microbiome. So could it also to change the composition of the oral microbiota? And that was our question. So we started looking into, the differences, or I guess the characteristics of the oral cavity. And we learned that, there's within the oral cavity, there's trillions of microorganisms, over about 700 bacterial species that have been identified in the mouth of a human. And these have several, obviously, functions and capabilities that are pretty closely aligned with our health, in a sense. So there has been close relationship between the immunity and microbiota, and there has been increasing evidence that show that there is a also to close relationship between these maybe oral microbiota inflammation with, say, insulin resistance, or even more, common systemic disease like diabetes and like a symptomatic atherosclerosis. So where there is this imbalance of microbial flora, there it causes some oral diseases. That the most common ones that we encounter are the dental caries, periodontitis, that's just the inflammation of the tissues around the teeth, the gums, and the ligaments around, and any disease of the oral mucosa, as well as systemic diseases like, again, diabetes and all that. So that said, patients with obstructive sleep apnea do show impaired function of their salivary glands, and there is a little bit less of this self-cleansing that we expect from the saliva to sort of partake within the mouth, and that alone has this defensive almost action, where the more saliva, the more this sort of washing away and this self-cleansing that happens, we sort of reduce all these oral diseases, in a sense, the caries, the periodontitis, all that. But also too, these OSA patients show this change in airflow, where the oxygen content and then the pH is also too disrupted. Sorry, this should be low. The L is dropped. So there is low diversity of microbiota, the same way that it did it for the GI. And the current literature suggests that buccal mucosal microbiome was significantly altered in pediatric OSA patients. And these are newer articles that are coming out. They are looking at this one that I'm quoting here, that just looked at the buccal mucosal area, and it's just in one spot going. It's not necessarily very dependable. So, and there's just not enough data, and most of them are pilot studies anyways. So here's one, again, recent one, that's a cross-sectional study looking into 40 only males, adults, were 30 to 65-year-olds range, 26 of them having OSA and 14 of them the non-OSA patients, and they excluded anyone that had history of atherosclerotic disease, MI, stroke, less than 6 months prior to the study, or congestive heart failure, diabetes, thyroid disease, and a bunch of other problems, any sort of respiratory disease. all that. And, or if they were on any anti-inflammatory drugs, let's say, or if they had central sleep apnea. So what they found was that there was a significant decrease in the bacterial biodiversity and abundance of the OSA group compared to the control. And the most significant decrease of this biodiversity and abundance actually happened within the moderate OSA group. There were two extremely different communities in the non-OSA and the moderate and severe OSA groups. The proportion of Neisseриas was the highest in the severe group, and the Glyciola cola was not detected in the moderate or the severe groups. And then there was a bunch of other ones distribution that was significantly, again, lowered in the severe OSA group. So another study that actually looked at the how these sort of the biofilm of these oral microbes over the tonsils. That's actually a pretty interesting area to be looking into. And they had 40 subjects. They actually looked at the ones that had OSA with no OSA, the mild, moderate, and severe groups. And a bunch of them that went actually before surgery, they looked at all of these individuals. And then the ones obviously that were candidates for surgery were also to 1 month after surgery were looked at. And then they did this DNA extraction and then the 16S RNA analysis on them. And what they found was that most patients with chronic tonsillitis had a layer of bacterial biofilm that was attached to the surface of their tonsils, and any changes in the upper airway microbiota could be therefore closely related to the presence of this pediatric OSA that was separated these groups from each other. One thing they noted was the variation in the alpha diversity, which I'm going to go over in a minute, across the distinct region of the upper airway among these children with OSA. That was especially around the tonsils, but this difference wasn't really found in the non-OSA patients. So just I mentioned alpha diversity versus beta diversity and what's the difference. The alpha diversity is the mean species diversity in the sites or habitats at a local scale. Beta diversity would be comparing the similarities or the dissimilarities of the microbial profiles between the different groups. And the total species diversity in a landscape, that would be the gamma diversity, is determined by these two. So the mean species diversity in sites or habitats at a more local level would be the alpha, and the differentiation among those habitats would be the beta. So at this time, there's only one pilot study that evaluates the oral microbiome from buccal mucosal swabs of children with OSA. And they reported a lower species diversity, and that was the one that I just quoted a few slides ago. So we wanted to observe the relationship between OSA and local flora and measure this diversity and abundance of local flora to be able to provide a new dimension for the analysis of local inflammation in OSA, and a new maybe clue and a viewpoint for pathogenesis of OSA. So our overall goal is to identify the oral bacterial species that are correlated with OSA. And this understanding is obviously we're hoping that it's crucial to achieve this precise microbiome-based approach to prevention and treatment of OSA-induced morbidity. And I think that's really, in the big picture, that's sort of our ultimate long-term goal. Our specific aims now for the project that we're hopefully embarking on over the next few weeks with Dr. Auerbach and their team here at BMC is to compare the oral microbiome in children with OSA versus healthy controls without OSA. And our working hypothesis is that the children diagnosed with OSA would exhibit microbial dysbiosis in comparison to the healthy control. And we would like to determine the difference in the oral host defense in children with OSA compared to controls without OSA. And for this, we're looking at the salivary characteristics. I didn't really go over that because it's a separate than the microbiome, but the characteristics of the biomarkers within the saliva low salivary flow, the pH, the buffering capacity, and any cytokines within the saliva and the inflammatory markers, the interleukins that we would be measuring to see how that oral microbial dysbiosis would have affected these. So we're starting out this project right now as a pilot case control study. We're going to be recruiting these patients of snorers without OSA, mild OSA, moderate, and severe, each group at least 30. And then we have the healthy, and these are going to be patients that are referred to BMC Sleep Center. Others that are going to be our healthy controls, whether kids that have gone through that sleep test and do not have OSA, or healthy controls that from our orthodontic department and the pediatric dentistry at BU, that would be the ones without OSA. And we are going to include, initially we thought about including 3 to 17 years old and maybe subdividing the ages, but now we're going to shrink that age gap so that analysis would be more relevant, especially for subcategorizing the severity of OSA, and male and female, and only English speakers because of the questionnaires that we're going to be using. Obviously, we have the PSG information, and the controls would be with the pediatric sleep questionnaire. And we have a bunch of exclusion criteria, ones that had orthodontic treatment in the past 6 months, any systemic conditions, neurologic disease, active oral disease, cavities, and periodontal problems, medical problems that make them unlikely to be able to provide a saliva sample, highly unlikely in that age group to have like really dry mouths, but still not impossible. And the ones that have been on antibiotics or anti-inflammatory drugs within the 6 weeks of this intake. And we're going to then collect the plaque sample with a swab from multiple areas in the mouth, and then that's where we're going to be collecting for the oral microbiome, and then doing a DNA isolation for the 16S rRNA gene sequencing. And we're going to have the children to be, sort of spitting in a cup, unstimulated saliva for a few minutes, and then we're going to look at that for analysis of the oral host defense. We're going to look at the salivary flow, pH, buffering capacity, and any inflammatory biomarkers within there with the multiplex immunoassay. And we're going to do our regular oral examination with, looking at their occlusion, the height of the palate, the width of the jaws, the Brodsky, the Mallampati, and we have them complete a pediatric sleep questionnaire, a beverage and snack questionnaire, and oral health behaviors. And ultimately, then we're going to use the most common technique, the amplicon for gene sequencing, that uses targeted primers to amplify the short regions of the genome using the polymerase chain reaction, or PCR, before sequencing. And then for the bacterial identification, we're going to use that 16S rRNA gene. That's approximately about 1,600 base pairs in length, and includes the 9 hypervariable regions, which require mutations at varying rates. So that's our plan, and that's all I have for you. And I hope that hopefully maybe by next year, next round of lectures, we'll have some interesting data to present. Dr. Orbach, I think you're muted.
There we go. Well, thank you. I wonder if there are any questions. I think everybody should be unmuted, where they're supposed to be unmuted. Maybe they're not, or maybe you can unmute yourself. Let me see if you, let me just see if I can do this. Hmm. I'm not very effective in doing this. I'm having some challenges here.
Sandy, I think it's allowing us to unmute if we want to ourselves.
Thank you. I was told that I had to unmute everybody. Okay. So are there any questions? Thank you. I have one. Goli, if there are these changes related to sleep apnea, does treating the sleep apnea reverse these changes?
And so that's exactly what, well, with the oral microbiome, we don't know because no studies have been done. But with the gut microbiome has been shown that the even changes in diet and changes in OSA does change the biodiversity. Yes. So
Back to the
yeah.
way, back to the original,
But I guess with
or close to the normal?
yes, close to, I guess, not significantly different from the normal patients. Yes.
Any other questions?
Hi, this is Samya Ayub. I'm, just fantastic talk and really looking forward to the findings of your research. My question is actually probably not related to microbiome directly, but about the rapid maxillary expanders that you shared. Do you also have any data on adults? Like, and are you guys doing it in adults if someone was interested in being referred to?
Sure. So with the rapid maxillary expansion, what we, if I can, I'm still sharing my screen, correct? You can still see my screen, right?
Yes.
Yes.
Okay. Let me try and see if I can go back here. Sorry, I don't want to make you all Parsi, but going back. Just want to show you the image I had that I sort of brushed upon quickly there. So here, as you can see, in the idea for rapid maxillary expansion is that we have these, so the maxillary bone that is in a way connected to the, sphenoid bone posteriorly via the pterygoid plates back there, around here, and then, sort of up superiorly with the frontal bone. So there is resistance where the sutures are, mainly superiorly and posteriorly. So when we try to put these palate expander appliances in that I had a few pictures for you, something like this, is sort of anchored onto the teeth. And then I also too had some pictures of different varieties of them here, as you can see. So there's different designs, but ultimately the idea is that we're applying the force down here, where now from around here, the force is pushing transversely sideways outwards. So for children, where the sutures, the mid-palatal suture is not necessarily fully fused, there is some interdigitation, but usually even well into the 20s, they're not really completely fused. And believe it or not, the majority of the resistance doesn't come from the mid-palatal suture, but it comes actually from the buttress in the back with the pterygoid plates and superior. And that's why I have these lines here where it shows that it's less resistance the more inferior we are and the more anterior we are. So with this force, we can actually get these separation where now you can see here the red showing most of the change versus sort of blue the least amount of change. You can see how with the lower we are, the more movement, that sort of pyramidal shape. The before is this sort of yellow area. I hope you can see my cursor, and the green is over it. Now with adults, to answer your question, the problem is not that we can't really, I mean, the same appliances can be put in, the same thing. The difference is that with the adults, the sutures are just so much more fused everywhere, and there's just so much more resistance. The same amount of force applied, now it's only going to push the teeth out of their bony sockets, more or less. I mean, I'm being very bleak about it, but that's essentially what can happen. There's going to be very little skeletal effect. So what we can suggest then is that in the younger adults, maybe around, 19, 20, 25 around then, maybe we can use these like bone anchors into the sort of the screws that go into the bone and try to apply this force like directly in the bone, or then use some, I mean, again, knowing that some of these resistance is coming from the bone, have the sort of do some cuts within the bone before. So we do what we call a surgically assisted rapid maxillary expansion, or SARP. So we're turning the adult in a way into a child by opening up the sutures, and then be able to go back and put these appliances in. I'm just saying this facetiously, but essentially we have put these appliances in, we have the cuts done, and then we can, now that we activate it, we can have pretty much the same result that we would with the child. It's just the difference with the adult and the child is the level of maturity of the sutures. I hope that answered your question.
Got it. Thank you.
Are there any other questions for Goli?
I have a question. So I know that the idea here is that if we show that you know, the change in microbiota is a consequence of OSA, and that's leading to metabolic derangement, that resuming the normal diversity could potentially have an effect at, you know, counteracting those changes. Is there any, you know, existing example of where that kind of approach has been shown to be effective for metabolic derangements? I mean, I know we usually think of probiotics as more of like a gut health and improving, you know, those kind of symptoms, but on more of a systemic nature. Is there any precedent for that?
No, I mean, like I said, the majority of the literature is I mean, gut microbiome has been studied the most out of all the microbiota in the body, and oral microbiome has just recently been studied. And like I said, we only saw one pilot study. As far as the you know, effect systemically on that, I couldn't find anything.
Any other questions for Goli? Well, I wanted to thank you. I found the whole thing quite fascinating.
Yeah.
And curious to see what's gonna come out of it as well.
Thank you so much. Thanks for inviting me. And yes, I look forward to this collaboration as a start of hopefully many long-term studies and exceptional findings, I hope. Yeah.
Thank you very much. Thank you,
Thank you.
everybody.
Thank you, everyone.